All right, a pleasant good afternoon, everyone. Well, as you know, I'm Dr. Ramsamoj, and we'll be continuing the series of lecture talks on vascular anatomy and cerebrovascular diseases tonight. We continue with part B of vascular anatomy. So basically, we would have covered anterior circulation last week, and we're gonna do posterior circulation and venous drainage to complete this week, followed up with aneurysmal hemorrhage, subarachnoids, vascular disorders, and then stroke in the coming weeks. So basically, picture of what we would have seen before. We know the vascular supply of the CNS, as we would have said, is really because of branches and anastomoses of the carotids and the vertebral arteries. And as we outlined earlier, we have an anterior and a posterior circulation that is connected. And last week we would have dealt with the anterior circulation, which is really, let me put on my which is the upper half, the middle cerebral, the anterior cerebral, the PICA that connects it to the posterior circulation. So today we're going to deal with the posterior or the vertebral basilar circulation, which on this second picture here is really what we should be focusing on in terms of that it originates from your vertebral arteries, okay, and then it both form the basilar artery and then they eventually become the posterior cerebral arteries. And then you have smaller segments or branches that we would touch on as well. Okay. Of course, just to remind us, the knowledge of the arterial vascular territories is important in terms of infarctions. And of course, because we're dealing with posterior circulation, these are the areas, the posterior cerebral artery in particular, that we would like to think of because when we talk about strokes, this becomes particularly important, just as in the anterior circulation, the vascular network of the posterior circulation is also susceptible to ischemic and hemorrhagic insults that can result in cerebrovascular accidents. Of course, posterior circulation infarcts, importantly, are characterized clinically by bilateral motor and sensory decline, cerebellar dysfunction, that's important, ipsilateral cranial nerve palsies, as well as disorders conjugate gaze. So without further ado, we'll get cracking into posterior circulation. So basically, this refers to the blood supply that supplies the posterior portion of the brain. It is supplied by the vertebral arteries that we see here. And like I would have mentioned, they combine to form the basilar artery and then they terminate into the posterior cerebral arteries that we see branch off on either side here. Of course, these are the main vessels, and you have smaller vessels supplying the posterior structures of the brain. That would include the posterior inferior cerebellar artery, PICA, and that's very, very important, and we will dedicate some time to that. The anterior inferior cerebellar artery, the pontine branches that you see here, as well as the superior cerebellar artery. So get started with the vertebral artery. It is the first and usually the largest branch of the subclavian artery that enters the foramina transversarium at C6 in about 90% of patients. So as we see, it comes off of the subclavian, like I would have said, and enters the foramina transversarium at C6. Usually, it goes all the way up 5, 4, 3, 2, and then it turns lateral at C2, and then travels posteriorly along the atlas, and then enters the scalvara, the foramen magnum. Importantly, as an overall picture, the vertebral artery supplies the pyramids inferior olivary nucleus, cranial nerves 10 and 12, and the reticular formation. So as we talk about the vertebral artery, we must get into the fact that there are segments of the vertebral artery. Okay, so we have our pre-foraminal, there are four of them, our foraminal and our extradural and intradural. Okay, so basically V1 or your pre-foraminal, as we can see here, and we get into exactly where they come from. We see V2 from about C6 to C2 and V3 extradural and V4 intradural. So just bear this picture in mind as we get along and we speak a little bit more about each segment of the vertebral artery. Of course, it's important to note that there are variants. And for instance, the left vertebral artery arises off of the aortic arch in up to 4% of cases, right? And the left vertebral artery tends to be the dominant one in 60% of the population. So we've mentioned we have four segments of the vertebral artery. Okay, so V1, like we said, it comes off of the subclavian artery, and this is the pre-foraminal. So in essence, from the subclavian to the transverse foramen of C6, which is outlined in purple. right? Now, importantly, as it relates to V1, some of the things that we want to bear in mind are the relations of the structures around it. So anteriorly, we need to remember on the left, we have the thoracic duct of the common carotid artery. Posteriorly, we have the ventral rami of spinal nerve C7 and C8. Anterior medially as well, we have our inferior thyroid artery. And importantly for V1 segment, we want to remember that it posteriorly is between the longus colli medially and the scalenus anterior laterally, okay? So that's important for us to recognize and remember. And then after it enters V2, after it enters that foramen at C6, it basically ascends vertically within the transverse foramen of the breast cervical vertebrae, 65432, okay? And it's surrounded with the stellate ganglion. And this is situated anterior to the cervical roots. And as I would have mentioned previously, it then turns laterally, and we can see it moved from the pink to that dark blue color that you're seeing there. It turns laterally to enter the foramen within the transverse process of the axis. So as we go along, now, once it gets here, it's going to exit this foramen of the axis and curves posteriorly and medially in a groove on the upper surface of the atlas and enters the foramen magnum. So importantly, at this point, V3, it is extradural from the transverse foramen of the axis to the vertebral canal. It passes superior medially, as we would have mentioned, of that posterior arch of C1. It enters the spinal canal by piercing that posterior atlanto-occipital membrane and the spinal dural arachnoid to continue as V4, which is this yellow portion that we're seeing here. And as we notice, it's very tortuous at that point between V3 and V4. And that's actually helpful because that tortuosity, what it does is that it provides the length and freedom of the vessel to stretch and straighten when we, engage in head rotation and bending of the head, which occurs primarily at the atlantoaxial joints. And then V4, as we would have mentioned, it's what is important here, this yellow portion here, is that as it ascends anterior to the roots of the hypoglossal nerve, cranial nerve, and it joins its contralateral vertebral artery at the lower border of the pons to then become the basilar artery. So we see from our subclavian straight all the way up through our foramen, turning posterior laterally, and then it joins our contralateral vertebral artery to become the basilar artery. So puts it into a little bit more into perspective for you instead of, the simple diagrams is that, well, like we said, we have our preforaminal and our foraminal, the first and second segments, right? Now, importantly, in these pictures that you're seeing here, this is basically from the C3 portion where this, or what some authors refer to as the suboccipital segment, right? And that becomes useful because when you have your suboccipital segment, you can actually find it within your occipital triangle, right? Now, in terms of the first major bend that we see here, bending posterior medially and then slightly anteriorly, so basically, after it makes that first bend posterior medially and then slightly anteriorly, it falls into a little groove on C1, which is called the sulcus arteriosus, which provides support. And then it has another little bend, which is hard to appreciate here, but this is a second bend and it pierces the dura and becomes intradural for C4. And you can appreciate here that this is actually C1 nerve root. This is a foramen magnum that obviously has been taken away for us to see. In this second picture here, we can appreciate that it goes under, it runs under cranial nerves 9 to 12. And basically it wraps anteriorly along the anterior cord and brainstem. And it hugs the brainstem as it's going up to the clivus anteriorly to form the vertebro-basilar junction. And how does it form that? It forms it with the contralateral side. So now that we've gone through, the course of it and the segments of it, importantly, we need to recognize the branches of it, right? So each of them, they have their branches. V1, we have your segmental, cervical, muscular, and spinal branches, as we can see here. V2, you have your anterior meningeal, muscular, and spinal branches. Now, your anterior meningeal, it's actually very important because it arises at the body of C2. Okay, so right here, the anterior meningeal arises. And what's important about the anterior meningeal is that it may feed chordomas or even foramen magnum meningiomas. And it actually acts sometimes as a collateral in vascular occlusion. Your posterior meningeal, which originates from V3, is also noteworthy because it can be a source of blood for some of our dural arteriovenous malformations, right? And then off of V4, the last segment that we would have described, you have your anterior and your posterior spinal arteries, your perforating branches to the medulla, as well as your posterior inferior cerebellar artery. Now, importantly, what we want to remember, because it can get a lot, is that the anterior spinal artery is responsible for supplying the upper cervical spinal cord and the inferior medulla. The posterior spinal artery is responsible for the dorsal spinal cord to the conus medullaris. And your PICA or your posterior inferior cerebellar artery is responsible for your supplying lateral medulla, tonsils, inferior vermis, cerebellum, choroid plexus, and the right? So let's just bear that in mind. Now, this table gives us a beautiful summary as to everything that we've just said, right? So it's really the quick hit table that extracranially you have your three branches, like we spoke about, spinal, muscular, meningeal branches, okay? Importantly, blood supply to the falx would be from your posterior meningeal branches as well, occipital, ascending, pharyngeal, and pica arteries. We've gone through the posterior spinal as well as the anterior spinal. The pica occasionally can actually arise extracranially, but 1 to 25% of vertebral arteries terminate as pica, and that's important for us to know as a variant anatomy. There are 5 segments, and we're going to go through these in details a little bit later. And importantly, we must remember that the strokes that are caused with pica would be laterally medullary syndrome or Wallingberg's, okay? So just to touch on our vertebral artery and our variant anatomy is that you can have asymmetry due to vertebral artery hypoplasia, absence or termination into the pica of one of the vertebral arteries. You can have complete or partial vertebral artery duplication, and you can have vertebral artery fenestration. Now, I want you guys to remember vertebral artery fenestration in particular. There's an incidence of only about 1% actually, with extracranial fenestration being more common than intracranial fenestration. But why we should remember it is that, in fact, you do have an increased association of intracranial aneurysms with vertebral artery fenestration. You also have a variable origin of your vertebral artery. Particularly, you can have a single left aberrant origin in up to 86% of cases. Followed by that, you can sometimes have a single right aberrant origin of 12%. There are, of course, several other origins, but these are rare, coming off of your ICA even, coming off of a second branch of your subclavian even. But importantly for you to remember is at least the big one, the single left aberrant origin, which, like I mentioned, could be as high as 86. Just to put some of these things into perspective, I spoke about having a hypoplastic right vertebral artery, which we can appreciate in photo A on the left, where we're seeing where this arrow is, the below arrow. In essence, this is the hypoplastic right segment of the vertebral artery. And it still goes on to form with the contralateral vertebral artery, the basilar artery at the second arrow that we're seeing at the top. But you would appreciate that there's a little bit of displacement opposite to what is the dominant vertebral artery, noted in figure A. Noted in figure B below, you could see, you've seen it before. This is exactly how fenestration looks. This is on an MRA. It was an incidental finding of fenestration of the distal left vertebral artery. In this case, there was no aneurysm actually seen. And in this picture, what I want you to appreciate is the aberrant left or the left vertebral artery that comes off of the aortic arch, right? Because we see this is the left subclavian artery. If you remember, I did say that it comes off of the left of the subclavian artery. Instead, in this picture, we see that it comes directly off of the aortic arch on the left. And in fact, the vertebral artery of aortic arch origin has actually been earlier described by different authors in the range of up to 8.3%, with an average of about 5% in terms of incidence. So I did mention that we are going to touch a little bit on the posterior inferior cerebellar artery by itself. It is a paired artery that originates from the vertebral artery V4 segment. Its origin is highly variable. I mean, 20% can arise extracranially, inferior to the foramen magnum. Up to 10% can arise from the basilar instead of from the vertebral artery. So if you can see your basilar, your vertebral, and this is your left pica that comes off here. And in essence, what it does is that it supplies that posterior inferior cerebellar hemispheres, the inferior portion of the vermis and the lower part of the medulla as well, and the inferior cerebellar peduncles, okay? Now, what this is that to actually show you the course, right? So where this star is, if you follow with me, in essence, what happens is that the posterior inferior cerebellar artery. It winds backwards around the upper part of the medulla oblongata, right? It passes between the vagus and the accessory nerve over the inferior portion of the cerebellar peduncle, and then it divides into two branches, right? And you have a medial branch and a lateral branch. Okay, so if we're supposed to follow here, this is where it comes off. Look at it in the purple, right? In essence, that is the anterior medullary segment, okay? So it comes off of the vertebral at the level of the medulla. Then it courses around laterally, right? And just try to mimic this to what you're seeing here. So it courses around laterally around the medulla, and then it comes inferior. And you see this loop, and this is the same loop that we see here. It comes inferior, and that is a classic what they call the classic course, forming the classic loop of PICA, right? And at that point, it in essence becomes your tonsillar medulla. And then it turns around and it comes back up, right? And when it comes back up, it basically comes back up as the next segment, which is here, right? As the tonsillar branch, right? And then it ends just under the cerebellum. And it's really hard to appreciate here, but here's the cerebellar tonsils, right? And that's where it ends as your cortical segments, right? So in essence, it's a very tortuous vessel. And there are five segments, and that picture, sorry, this should have helped to underline the five segments that you would see. Your anterior medullary in purple, your lateral in blue, your tonsillomedullary coming across, and then your teleovalotonsillar, and then your red branches being your cortical. So like I would have said in essence, you have five segments defined microsurgically as per Lister et al. Anterior medullary, lateral medullary, tonsillomedullary, teleovalotonsillar, and cortical, okay? Now, why talk about PICA? I mean, PICA is of actually great clinical importance because of its complexity in terms of its unique anatomical complexity and the fact that it's involved in many diseases, including not just ischemic strokes and aneurysms, but also in AVMs, tumors. And also, in addition to that, is the fact that the PICA tends to be exposed in many surgical approaches and is vulnerable to injury and damage, right? So it's important that we know the key anatomical features of PICA, and in fact that we know there are five segments. It's been thought that during surgery, at least the first three can be preserved, even if the last two can be sacrificed with minimal deficits, right? So one of the other things I want you to recognize is from the anterior medullary, you also have branches, right? So in essence, the anterior medullary runs from the origin, sorry, from PICA origin to the inferior olivary prominence, and it gives off branches to the ventral medulla, okay? Then the lateral medullary, from the origin of cranial nerve 9, 10, and 12, and 11, sorry, and it gives off up to five branches, and you see them here, right? 9, 10, and 11, and up to five branches that supply the brainstem. And then the tonsillomedullary, which is in purple again, that basically what that does, and that's important for us to recognize, is that it basically marks the transition between the proximal, which is medullary supply. And because remember I said the anterior and the lateral basically supply the medulla. And so it marks the transition between the proximal and the distal part of the pica. And now the distal part of the pica is what goes on to supply the cerebellum in essence. So that teleovalotonsillar portion in green that we're seeing and the cortical branches, these go on to supply, to give rise to choroidal arteries, and they go on to supply the cerebellar surface itself. So while we're still on PICA, there are two trunks, a medial and a lateral trunk, and there are three branches, the choroidal artery and the terminal branches. Now, the main trunk of the posterior inferior cerebellar artery usually bifurcates somewhere along the margin of the cerebellar tonsil into the medial trunk, which supplies the vermis in the adjacent hemisphere, and then the lateral trunk, which supplies the tonsil and the hemisphere, and the branches of the choroidal artery and the tonsillar branches. And like we would have said, that they eventually, these terminal branches supply the choroid plexus as well as the cerebellar surface, okay? Now, this is just snapshots to remind us of where we are, what we're talking about, just in case you guys fall asleep. So we have vertebral artery, and they come together to form the basilar artery, okay? And this is your pica coming out, and we talked about cranial nerves 9, 10, and 11 coming out. I mean, this one is a little, obviously there was some manipulation, but really and truly this is how it should be looking, coming along smoothly along the brainstem. In this picture, the brainstem has been removed, and you can see it quite beautifully. Your verts coming up, eventually forming exactly what you just saw there, the basilar artery, pica, and this is actually, you could actually see in the middle here, the anterior spinal artery going to the spinal. And to round up on the posterior inferior cerebellar artery, the anatomic variants. And these are actually classed A to F. Just for the sake of knowledge, A would be a fenestration of your pica. B, you have a double origin of your pica that you could see here and here. C is where you have a ICA-PICA variant where it originates above from the ICA, and then D, you have it originating from the basilar artery. So remember I said that it originated from the vertebra, but in this you can clearly see that where PICA originates is above the bifurcation or above the vertebro-basilar junction, I should say, um, originating from the basilar artery. So that's D. And then E, you can have an extradural origin altogether. And the last one is that exactly what we see, that the vertebral artery sometimes terminates in the pica. So we see that the vertebral artery here actually terminates in the pica and doesn't go on to join with the contralateral vertebral artery to form the basilar artery. So we're moving swiftly along. We've gotten to basilar artery. So we should all be very familiar with the fact that both vertebral arteries come up to form our basilar artery. So it arises from the confluence of the left and right, like I would have mentioned, that occurs at the base of the pons as it rises and they rise towards the base of the brain. So in essence, what I want you to appreciate here is that the basilar artery runs cranially in the central groove of the pons towards the midbrain within the pontine cistern. It travels within this groove from the lower pontine border adjacent to the exit of the abducens nerve to the upper pontine border at the appearance of the oculomotor nerve. So that's important in terms of your anatomical relations, as you want to know that it runs along adjacent to the exit of the abducens or cranial nerve 6, and as well as you would then see your oculomotor nerve. And it then bifurcates at the upper pontine border into the terminal branches, which are the posterior cerebral arteries. So it divides into two terminal branches, your posterior cerebral arteries, and several smaller branches, which we touch on. Now, branches of the basilar artery, the anterior inferior cerebellar artery, which we see here, our internal auditory artery or labyrinthine artery, pontine branches, like we mentioned, superior cerebellar artery, and posterior cerebral artery. Okay. Now, this table summarizes beautifully everything that we basically need to know about all of these branches. I mean, the one that we're going to definitely talk about would be the posterior cerebral arteries, or ICAs as we know. It supplies cranial nerves 7 and 8, or pons, middle cerebellar peduncle, anterior lateral hemispheres. Of course, the labyrinthine artery goes to supply what? Structures of the labyrinth. Paramedian and pontine arteries would supply the ventral pons, and our superior cerebellar artery, importantly, as it travels posterior laterally below the tentorium and cranial nerves 3 and 4, it supplies the superior vermis as well as the cerebellar hemispheres. Okay, so pay attention and review this table as you need to as we move on. A basilar artery, we can't leave it without talking about the anatomic variants. And you can have basilar artery hypoplasia. You can also have fenestration, and you can have persistent carotid basilar artery anastomosis. Now, the thing with basilar artery hypoplasia that we need to recognize is that usually it's accompanied by one or more in terms of the features, in such as it can have a unilateral or bilateral fetal origin of posterior cerebral artery, and it's usually accompanied by persistent carotid basilar artery anastomoses as well. And we have that talk a little later in this very presentation, so we leave it for then. What I want you to take away from this slide in terms of anatomic variants and the basilar artery is basilar artery fenestration. Why? Because it is the most common intracranial arterial fenestration. It is the most common congenital anomaly of the basilar artery. If you don't remember anything about the anatomic variants, at least remember that the basilar artery fenestration is the most common and it is the most common congenital anomaly. And in essence, what it is that it's a variant that is characterized by duplication of a portion of the artery that are connected proximally and distally, right? Or persistent carotid basilar artery anastomosis. As I said, these are variant anatomical arterial communications between the anterior and the posterior circulations due to abnormal embryological development. And like I said, we would go and talk about these a little later. Now, because the fenestration is so important, and I'd like for you to remember it, um, I've included pictures of you for you to see the CT. On CT, you can see that fenestration of the basilar artery right here. And coming across on this DSA, we see the fenestration, and I've included one where you actually see an aneurysm as well, because fenestration, like I said, predisposes to basilar artery aneurysm. I mean, it's been thought presumably due to abnormal flow dynamics. The magnitude of risk tends, it's not really clearly categorized. It's inconsistent across studies, but fenestration associated aneurysms is real. It most often occurs at the vertebral-basilar junction. They tend to be saccular in morphology, and the prevalence tends to be about 7%, and that is based on literature by Dimick et al. In 2009. So even though it's not, uncommon, and it's usually an anatomical variant, what is important and the key takeaway as well is that you have an increased incidence of cerebral aneurysm with basilar artery fenestration. On the terminal branches, the posterior cerebral artery. So the posterior cerebral artery courses, and you can see this is a right posterior cerebral artery. You can see here. So in a sense, it courses from the basilar artery towards the occiput around the cerebral peduncle over the tentorium. It supplies the occipital lobe, posterior medial temporal lobes, midbrain, thalamus, choroid plexus, and part of the lateral and third ventricles. And of course, we won't be talking anatomy unless we talk about segments and branches. So again, the posterior cerebral artery has 4 segments: pre-communicating segment, ambient segment, quadriminal segment, and terminal cortical branches, right? So terminal branch, which we're going to start right here, as you can see, basilar, posterior, right? So pre-communicating, in essence, it's going to extend from the tip, this is P1, it's going to extend from the tip of the basilar artery to the PICA origin. And this PICA origin is exactly where this dotted line is coming to that you can see that's joining the anterior and the posterior circulation, right? That is your P1 or your pre-communicating segment. And then P2 is your ambient segment, which extends from your PCOM to your dorsal aspect, and you run it along here because you're seeing P2 now, labeled clearly, coming down, and it's running down to P3, right? It runs along the dorsal aspect of the midbrain, that is P2, and you actually have a P2A and P2B, right? P2P, sorry, anterior and posterior. And then P3, as you can see here, is a quadriminal segment, like I said, which extends from the lateral portion of, as the name suggests, the quadriminal cistern origin. And right there is also where your posterior temporal artery comes off, okay? And the anterior limit would be that of the calcarine fissure. And then you have P4. So here is P3, and it ends at the anterior limit of the calcarine fissure. And then P4 comes down as your terminal cortical branches, pre-communicating ambient segment, quadriminal segment, and terminal cortical branches of your posterior cerebral artery. Okay, so just to make sure we're still all on the same page, vertebral, basilar, posterior cerebral. We've done anterior cerebral last week. So we're coming up vertebral, basilar. This would be what? P1 segment, okay? This would, number 6 would in essence be what? P2 segment, 7, P3 segment, and then of course, P4 segment as we're coming down to our cortical branches, right? So we've done segments, we need to do branches. So the P1 segment, again, this is showing a different view of it, but showing it beautifully. Your P1, your P2A, like I would have said, P2P, P3, and P4. Of note, sometimes the P1 goes by other names instead of pre-communicating. It can be referred to as mesencephalic, can be referred to as peduncular, basilar, but basically, again, from the origin to the posterior communicating, so communicating artery, and it gives off branches, long and short circumflex and thalamoperforating arteries. P2, origin from PCOM to the inferior temporal, and it traverses the ambient cistern, the ambient segment, hippocampus, anterior temporal, peduncular, as well as you have medial posterior choroidal arteries arising from here. Your P3 or your quadruminal segments, again, that we saw from the origin of the inferior temporal branches, right? So the origin of the terminal branches. And your terminal branches would be P4, which is named after you have calcarine and parietal occipital arteries and your cortical branches there. So we have several tables summarizing these segments and the important features about it, okay? What I want you to remember and take away from your P1 segment, we've explained the branches already, is your medial posterior choroidal arteries, because you also have lateral choroidal arteries. So your medial arteries in particular, they supply the midbrain, the thalamus, the pineal gland, and the tilia choroid of the third ventricle. And again, this is just to remind us of the segments that we're going through for the posterior cerebral artery. P2, like I said, so the important one for the P2 would be a lateral posterior choroidal artery. And again, this is the main branch of P2. So P1 segment, biggest one that you need to remember, well, there's three, but the biggest one is the medial posterior choroidal artery. P2, I want you to remember the lateral posterior choroidal artery at least. It is the main branch, like I said, and it supplies the posterior portion of the thalamus and the choroid plexus. And of course, you have your thalamogeniculates arteries and your cortical branches as well, right? And what actually ends up happening is that these same lateral arteries, these lateral posterior choroidal arteries, actually enter the choroidal fissures and the anastomose with the anterior choroidal arteries, forming a variable anastomotic network as well, right? P3, posterior temporal arteries, parieto-occipital arteries, calcarine, posterior pericallosal arteries, all things that we've said in terms of what they supply, the posterior temporal lobe, as you saw from the diagrams that are coming down. In fact, the posterior temporal artery, importantly, anastomoses with the middle cerebral artery as well. Parieto-occipital artery anastomosis with the anterior cerebral artery. And what all of this really goes to show us and remind us is that we're ultimately trying to remember and understand how the circle of Willis works and how the brain is able to, and how we have this rich anastomotic network in essence that ensures that we have complete circulation and we always have good collateral circulation, even in the presence if we have occlusion by chance. No, I would have said that the posterior cerebral artery has four main segments, and surely most literature describes it as four. But for the sake of completion and just to know what's out there, there's other literature that actually just divides it as three segments named for the surrounding systems, which is P1, P2, and P3, which would be the peduncular, the ambient, and the quadruminal segment, right? So I've just basically included that for the sake of completion. And I've gone ahead and given you a table in terms of what branches that they've suggested comes from what based on P1, 2, and 3. But in essence, where it really falls is that they've just basically said that P4 branches come off of the quadruminal segment as well. What I do want you to take home from this slide is the artery of Percheron coming off of P1 or the peduncular segment. Why? Because it's a rare anatomic variant in which you basically have a solitary arterial trunk arising from the proximal segment of one PCA that supplies the paramedial thalami and the rostral midbrain bilaterally. It's estimated to actually occur in up to 12% of the population, right? So because it supplies the paramedian thalami, most often the rostral midbrain bilaterally, an infarct becomes very dangerous. So when you have these infarcts, patients come in clinically, they're obtunded, they're comatose, they're agitated, they could have a gaze palsy, they come in with memory deficits. It's actually an entire triad. So that's important to recognize the artery of Percheron, which some people have, like I said, between 4 and 12% of the population. So where are we? By now, you should really and truly have known everything about the circle of Willis. What we do need to remember is that there's considerable anatomic variation that exists within the circle of Willis. Classic anatomy is truly only seen in up to a third of the population. I mean, back in 1664, we have to give credit to Sir Thomas Willis, who would have coined and he would have described this beautiful vascular arrangement that we see here, laying at the base of the brain, accompanied with drawings to prove to the medical world that, hey, I've reached perhaps the greatest, well, not perhaps, but the greatest understanding at that time of structure and function of the circular arterial anastomosis. But what is more important for us to recognize, and I would have alluded to it earlier, is the fact that outside of the arterial surface, the fact that Willis was actually able to correlate the anatomy with physiology and the clinical picture, and that he's saying, well, listen, this arterial network, it's It was designed to maintain cerebral blood flow and regardless of obstruction of any of the ICAs. So truthfully, Circle of Willis, it's one of the most renowned eponymous structures perhaps in human anatomy, and that has really marked a significant transition between, medieval times and modern medicine. So, like we said, the anterior and the posterior cerebral circulation between both of them, it allows us to perfuse the brain and to protect against ischemia, sorry, at least in those with a complete or mostly a complete ring of vessels. Outside of the entire cycle of Willis that we would have just mentioned, there are some smaller vessels that you do need to know. These are the penetrating arteries of the cycle of Willis, the anterior medial arteries that help to supply anterior hypothalamus and the nuclei. Posterior medial arteries supplying the hypophysis and fundibulum as well as the hypothalamus, and the anterior lateral and posterior lateral that aid in supplying your thalamus, right? These are just your penetrating arteries of the circle of Willis that helps to make sure that we have flow all around. So just to correlate this a little bit with our regional blood supply, because we've gone into each branch and each segment and where they go and what they do and what they don't do. But in terms of our structures, major structures, striatum, internal capsule, thalamus, medulla, pons, midbrain, cerebellum, and major blood supplies. So striatum, mainly our MCA, internal capsule, the anterior limb is our ACA, you know, the ICA perforator. So this table basically just gives us that nice, well-rounded summary of our regional blood supply, okay, and our cerebellum or PICA, and our superior cerebellar peduncle as well, okay, and of course each of these would particularly remember when we do our stroke syndromes, because then we get into which one is affected and which one we suspect has an infarct in our stroke syndromes. Again, this is simply to help us in remembering exactly what supplies what. Here we have the structures mimicked on one side and the regional blood supply outlined on the other side to aid us in remembering the areas that the major arteries would supply. So we cannot complete the arterial supply without talking about our fetal carotid vertebrobasilar anastomoses. And these are basically persistent fetal anastomoses that result from failure to involute as the vertebral arteries and the posterior communicating arteries develop, right? I mean, generally they are asymptomatic, but you have some that are associated with vascular anomalies such as aneurysms, AVMs, and this is why it's important that we just have to do it for the sake of completion and to know that it exists. There are 4 types that are recognized, and 3 of which are associated with a cranial nerve. The persistent primitive trigeminal artery represents the most common form of it, all right? Now, the 4 that we're going to talk about is the trigeminal, and you see them here. You see the abnormal connections, right? They didn't involute the trigeminal, the otic, the hypoglossal, as well as the proatlantal, right? So we're just going to run through these. In essence, type 1, persistent primitive trigeminal artery, right here. We see it between our ICA and our vertebral artery, right? And our basilar, sorry. It's seen in 0.6% of cerebral angiograms, and like I said, it connects the cavernous carotid to the basilar artery, and it is the most common of the persistent fetal anastomoses. Up to 83% of cases would have this one. It can be associated with trigeminal neuralgia. Of note, for those of us who are very interested in neuro, characteristic toe sign or trident sign is what we're going to see on CTA or MRA or MRI. Why is it important? The PPTA is that related pathology, there's also an association with intracranial aneurysms and vascular malformations. There are 3 variants, type 1, 2, and 3, Saltzman. These are, I've just included it so that we can know it. Becomes in type 1, the PPTA supplies the distal vertebrobasilar arteries. In type 2, it supplies the posterior cerebral artery, and type 3, it joins the FCA. Right, and we can go further into describing the different types of type 3. There are 3 of them. There's type 3A, B, and C. We can read a little bit more of that on our free time in the interest of time. Type 2, otic. This is very, very rare. There's only about 8 cases reported worldwide. And it makes sense because the otic is actually first to involute. So if it's the first to involute, it makes sense that it's the rarest to persist. But basically, this passes through the internal acoustic canal to connect the petrous carotid to the basilar artery, as we can see here, right? Like I said, only 8 cases reported worldwide. The hypoglossal present in about 0.2% of the population. And what this does, and we see it right here, is that it connects the petrous, or the distal cervical ICA, to the vertebral artery, and it traverses the hypoglossal canal, right? It's not cruciform and magnum. Now, this one is a little important to remember because it is the second most common in frequency. So the PPTA, or the trigeminal artery one. It actually occurs a little bit more frequently, up to 6 times more often, but the overall incidence is low, 0.2%, like I would have mentioned. And type 4, pro-atlantal intersegmental, only about 40 cases reported so far. And this connects the cervical ICA to the vertebral artery. And if you remember from our last lecture, the cervical ICA would have been the first. So it arises from the bifurcation of the common carotid, or the ECA, or the ICA from C2 to 4, and then anastomoses with the vertebral artery in the suboccipital region. Because we want to be a little bit extra and know a lot, there are two types of type 4, pro-atlantal intersegmental, in terms of there's type 1 on the left and there's type 2 on the right. And type 1 actually occurs in up to 55% of patients. What is the difference between it? Type 1 corresponds to the first segmental artery, and it arises from the internal carotid artery. The difference between type 1 and type 2 is that type 1 arises from the internal carotid artery. Type 2 arises from the second segmental artery, or the external carotid artery. As you can see here in this 3D reformation, you can see the nice pro-atlantal artery here. In essence, it's a prominent branch of the left ECA, right? So 1, ICA, first branch, 2, ECA, second branch. And to round up today's lecture, we're going to just touch on the venous drainage of the brain. Now, the cerebral veins are divided into the external and the internal cerebral veins. They drain the external surfaces and the internal regions of the cerebral hemisphere. So, 4 things we need to know: diploic veins, meningeal veins, dural sinuses, cerebral veins, and you've got it covered. Diploic veins, these communicate with the scalp, the meningeal veins, and the dural sinuses. The meningeal veins, these are the epidural vessels of the dura, which follow the meningeal arteries. So drainage into the dural sinuses or into the extracranial vertebral plexus would occur. Dural sinuses, what is important? We don't have valves, and these communicate with the emissary veins. And of course, our cerebral veins would then be our superficial veins and deep cerebral veins. So the basis of venous drainage of the brain hinges on these 4 things that I've just explained to you: diploic, meningeal, dural sinuses, and cerebral veins. Now, key facts that you need to know about the venous drainage of the brain on a whole. Like I said, yes, it comprises of your cerebral veins and veins of the brainstem and the cerebellar veins and all the 4 things I just said a while ago that eventually drain into intracranial dural venous sinuses and then eventually into internal jugular veins of the neck. Characteristic features that you do need to know, however: this is not one of those times when we could say the venous drainage follows the arterial supply. No, it does not. So the venous return in the brain does not follow the arterial pattern. The veins of the brain are extremely thin-walled due to absence of muscular tissue in their walls. There are no valves. And the veins of the brain are mainly in subarachnoid space. So these are key elements that you need to remember as we talk about venous drainage of the brain. So did mention external and internal. The external cerebral veins, they drain the surface or the cortex of the hemisphere, and they're divided into superior, middle, and inferior. Like we said, the external drains the superficial and the internal drains the internal regions of the cerebral hemispheres, respectively. So, superior cerebral veins that we can see nicely at the top here, draining into a superior sagittal sinus. They drain naturally the upper parts of the superior lateral and medial surfaces of the cerebral hemispheres, right? Now, the anterior veins, they open at a right angle, while the posterior open obliquely against the flow of bloodstream in the superior sagittal sinus. And that makes sense, because what it does is that it helps to prevent the collapse by increasing your CSF pressure. Importantly, there's about 8 to 12 of your superior cerebral veins, and they pierce the arachnoid mass and traverse the subdural space to then enter the superior sagittal sinus, right? So keep this picture as we go along in your minds. Middle cerebral veins, and there's usually 4. There's 2 on each side. You have a superficial and you have deep. So superficial lies superficially in the lateral sulcus, and the deep in the sulcus. Right? So when they run here, as you can see, anteriorly it runs forward to drain into the cavernous sinus, while posteriorly it's going to communicate with the superior sagittal sinus, as we see here. via the superior anastomotic vein of Dural, and with the transverse sinus via the inferior anastomotic vein of Dural. Right? So superior middle vein, anteriorly it's gonna hit the cavernous sinus, posteriorly it's gonna go into these anastomotic veins. So then end up into your transverse sinus. And your deep middle cerebral veins, these lie in your deep sulcus, like I said. These run along with your middle cerebral artery, please remember that. And they run downwards, forwards, and joins the anterior cerebral vein to form the basal vein. Inferior cerebral veins, many in number, small in size, drain the inferior surfaces of the lower portions of the medial and superior lateral surfaces of the cerebral hemisphere. I did speak about the anterior cerebral vein. It's important to know it runs along the anterior cerebral artery around the corpus callosum and helps to drain the medial surface that cannot be drained otherwise into the superior and the inferior sagittal sinuses. Basal vein of Rosenthal, and you see it right here. Now, this is formed at the base of the brain in the region of the anterior perforated substance by the union of three veins: the anterior cerebral, which I just mentioned, the deep middle cerebral, which I told you ran in the deep portion of the lateral, and the striate veins. And these striate veins, they come from right there as well. They come from the anterior perforated substance. So together they run posterior. So they unite to terminate into the great cerebral vein of Galen below the splenium of the corpus callosum. And the basal vein, in essence, now, like I said, this is basal vein, it runs posteriorly around the midbrain, medial to the uncus and the hippocampus, and terminates in what I just told you, the great cerebral vein of Galen, right? So basal vein terminates into great cerebral vein. Of course, there are other veins, as well as those three veins I just mentioned, that help to form the basal vein. So the basal vein, in essence, receives other tributaries from the cerebral peduncle, the uncus, parahippocampus, structures of the interpeduncular fossa, optic tract, and olfactory horn of the lateral ventricle. So internal cerebral vessels are the next big one you need to know. There are two. They're located on either side of the midline. It's actually formed at the interventricular foramen of Monroe by the union of three veins now. Again, thalamostriate, septal, and choroidal, right? So three veins is what unite to form the internal cerebral vein. And these are important veins. As their names imply, the thalamostriate, it drains the the thalamus and the basal ganglia. The septal vein drains the septum pellucidum, and the choroidal vein drains the choroid plexus. And together, they form the internal cerebral vein. And then these run posteriorly, unite below the splenium, corpus callosum, to again form the great cerebral vein of Galen, which then empties into the straight sinus. So it's like building. It's you just build in with each piece of information I give you, right? So now we're at the great cerebral vein. What is it? Ding ding. It comes from the union of the two things we just talked about, the two internal cerebral veins and the basal veins. So it's a single vein. It's usually about 2 centimeters in length, formed again by the union of two internal cerebral veins, and it also receives the two basal veins. After a short backward course, it joins the inferior sagittal sinus to form this straight sinus, right? So the tributaries of the great cerebral vein are the internal cerebral veins, the basal veins, other random veins from the colliculi and veins of the cerebellum. But the big ones are the internal cerebral veins, which you see here, and the basal vein, which you see here, join into form what? Great cerebral vein of Galen. Sinuses, last but by no means least. So all the important things we talked about: basal vein of Rosenthal, internal cerebral vein, superficial middle cerebral vein. Again, you see it, the sigmoid sinus, the transverse sinus, the straight sinus, vein of Galen, and eventually these are going to come down and drain into the internal jugular vein. And that's how ultimately the cerebral vessels are drained, right? Summary slide. Everybody loves this. The superficial veins, deep veins. So superficial veins, let's make it easy. Superficial middle cerebral vein, like we said, drains in anteriorly into the cavernous sinus. Posteriorly, if you remember the picture, drains into the superior sagittal sinus via trolad or into the vein of Lavi and the transverse sinus, right? You also have a couple of anastomotic veins, superior and inferior, right? Superficial veins, just remember, in essence, it drains mainly into the superior sagittal sinus, which ultimately then drains into your right internal jugular vein. And you have your deep veins, internal cerebral, basal vein of Rosenthal, and vein of Galen, which we've just gone over at least 3 times. These, in essence, drain mainly into the great cerebral vein, which then drains into the left internal jugular vein. So concluding slide would be superficial, drains into your superior sagittal sinus, which eventually goes into your right internal jugular, and your deep veins into your great cerebral vein, into your left internal jugular vein. Dural sinuses. Superior sagittal sinus, inferior sagittal sinus, transverse sinus, sigmoid. So in essence, our superior sagittal runs from the foramen cecum to the internal occipital protuberance. And I know we all have a mental picture of what that is like. And it predominantly drains up to 60% of the right transverse sinus, right? And then you have the inferior sagittal sinus draining into your straight sinus, right? Just remember the picture, and drains predominantly into the left transverse sinus. And then you have that transverse sinus, which just from the confluence, which courses laterally and then curves towards the occipital petrosal junction to become the sigmoid sinus. And the sigmoid sinus is just as the name suggests, it's because of its shape, S-shaped. In essence, it courses along that temporal bone to become the superior jugular bulb at the jugular foramen, right? And receives blood from the inferior petrosal sinus. And that confluence, right, which is a dilatation at the internal occipital protuberance that communicates with the superior sagittal, the straight, the transverse, and the occipital sinuses, right? Not to be left out, your petrosal sinuses, superior and inferior. Superior receives from your pons, medulla, cerebellum, and inner ear, and inferior from your cerebellum and labyrinthine veins. And your cavernous sinus. We all yap about cavernous sinus. We're all scared of cavernous sinus thrombosis. It drains into your superior petrosal sinus, which then drains into your transverse or your sigmoid sinus, your inferior into your internal jugular. And it communicates with several other sinuses. For the sake of explaining the cavernous sinus very quickly, we know there are 1 centimeter wide cavities that extend about 2 centimeters from the most posterior aspect of the orbit, and you can see it here, right? And there are paired venous sinuses that sit on either side of the sphenoid bone, right? And of course, in the lateral walls, we have an ocular motor nerve or internal carotid, ophthalmic nerve, abducent nerve. And like I said, what drains into these? Superior ophthalmic vein, inferior ophthalmic vein, middle cerebral vein, middle meningeal vein. All right, so that's just a tidbit on the cavernous sinus. And to wrap up, this is the beautiful picture showing us everything that we just spoke about. Superior sagittal sinus, inferior sagittal sinus, right? Great cerebral vein coming down into a straight sinus. Confluence of sinus has what? Where they all connect, right? And then from the confluence of sinus, it then comes down into our superior jugular bulb and into our internal jugular veins, right and left, and then to go back to our cardiac or to heart, right? And to end off, in terms of venous drainage, some of the key things you need to remember in terms of clinical correlates would be cavernous sinus thrombosis, venous sinus thrombosis, subdural hematomas, and developmental venous anomalies. And we're really just touching on these for the sake of completion. We know that cavernous sinus thrombosis results from obstruction, inflammation, anything that increases pressure within that cavernous sinus, and some of the typical causes would be thrombophlebitis, persons with a hypercoagulable state. Cerebral venous thrombosis, however, venous sinus thrombosis, it involves the dural sinuses and the cerebral veins. It's uncommon, but it tends to affect young people. Most of the persons it affects is about 78% less than 50 years of age. And there's actually 3 types. You have your dural sinus thrombosis, cortical and deep venous thrombosis. We're not trying to do a whole class on this. It's just for you to be aware of in terms of correlates to venous drainage. And of course, subdural. By now, we all should know what an acute and a chronic subdural is. Of course, we know that most cases are traumatic in terms of because you have injury to your bridging vessels from cerebral acceleration and deceleration injuries. Patients can be on anticoagulation causing this as well. The risk is 7-fold in men and 26-fold in females. And then developmental venous malformations, or generally we're going to talk about that in our vascular malformations class, but basically these anomalies are because you have a vascular malformation of the brain, even with normal intervening brain being present. And basically what it is that you have a single dilated cerebral vein with surrounding tributary veins draining into it, as opposed to several small separate veins. So basically put is a vein that's draining more than its fair share of parenchyma. And you only see it in about 3% of the population. But that's just some clinical correlates to keep in mind and to read about in advance, because we are going to have a talk on vascular malformation. And that brings me to the end of today's presentation.